Hi, everyone. Welcome back to the podcast. Welcome all new listeners. Welcome back to those who have heard my content in the past. If you want to know what you're missing and what to look for inside back pain treatment, you have to tune into this episode. Before I go on to the podcast, what is new? What is better in life? My son, Zach, if you guys are been following for a while, my son Zach just impressed me. He said, "Hey, Dad, uh, can we play chess before going to school?" I said, "Yeah, absolutely." And I gave him about 5 minutes, so that way we had enough time to complete a game in 5 minutes. And he took me beyond the 5 minutes at the age of 6 with no real training behind the scenes. He actually pushed me to the limit. I was actually very, very impressed. I think he's been watching a lot of YouTube videos on how to play chess. So that is new. I almost got beat by my son at the age of 6. So appreciating that. My daughter's doing awesome. She's loving gymnastics and jujitsu. Jacob is the heart of the family, and doing amazing and learning new words here and there. And then my wife is doing awesome. If you guys don't follow me on Instagram, I recently posted that I was celebrating some wins. My heart rate, my resting heart rate, just got to about 48, which is great. I've hit 42 or 44 before, and I finally hit 48 again. And my HRV, I think I'm at like a 48 to 62, maybe somewhere in the range. And I posted online, and my wife shows me a screenshot of her metrics. She's a 44 for a resting heart rate and an HRV of 88. So she is absolutely crushing me. So that's where I stand currently. All right, on to this podcast. What is happening? All right. Why are we talking about back pain? Well, back pain is probably the most common thing you see inside your clinic, or you have seen in your clinical rotations, or you've seen at different clinics. It's just so prevalent, right? So the reason why I'm bringing this up is because my wife and I had a really good conversation recently. I said, "Hey, what's your favorite body part to treat? Like, what is the absolute like favorite?" And I can tell you, I already knew this answer because she's really good at it. She's a physical therapist, and she's really good at shoulders. Like she can just do it in her sleep. And I said, "What's your worst? Like, what's your least favorite or least confident, or what do you second guess sometimes, right?" And she said low backs, and I was like, "Oh, I love low back pain. I love SI. I love low back. I love hip. All three of those together probably encompass. If I can treat that all day, I would do it. I honestly would. I have a passion for it. I love. For some of you, you might be the wrist or the elbow or the knee expert or whatever it is, and I wouldn't even call myself an expert. I just have a lot of love for it because I still you get complex cases, but the people who are able to see it differently, they can put the pieces together. Those are the ones who have the best outcomes. So after talking about this, and I then started talking to some of the physical therapists that I mentor about back pain. They said the same thing. They're like, we don't. It doesn't come as easy to us, and it's a little bit more complex. And as you know, I just did a session this morning, and I said, it's real simple, and I want to share today the outline that I gave and how it could really help you, and like what you're missing inside the clinical practice, and maybe the pieces to the puzzle that you're not seeing, but it could be so basic, and I'll break that down for you. So that's what we're talking about today. Low back pain, conservative management. What are you doing with it? What are you missing from an evaluation treatment or evaluation standpoint, a treatment standpoint? So let me get you guys started here. So the fear that I hear from a lot of therapists is that it's very complicated. Sometimes it's a referral source. Sometimes it's coming from different regions. Sometimes the patient's non-compliant. Sometimes the therapist doesn't have the confidence that's going to get better. And in a meeting today, that was a concept we covered. That ultimately patients come to you for a reason, right? They want a solution to their answer, to their problem. And the person they stick with is the one who has the most confidence or certainty, right? And as a therapist, it's kind of tough because, there's different terms out there, fake it till you make it, or the imposter syndrome, whatever you want to call it. But I think that um, if you don't feel confident you're going to manage it, it directly affects what your outcomes are, whether you can get the outcome you want, or even if you had all the tools, can you confidently sequence this rehab process so that they are actually getting better at the rate that they want? And for a lot of clinicians, that's scary. It's daunting. It's complex. They're not sure if they can do it, and I understand that. I've been there, and the complexity of the low back between the SI, the hip, and any potential referral sources makes it even harder. So I get that. So I'm going to give you guys some tools to take the pressure off and allow you to be a little more seamless in your thought process. So I'll start with the evaluation process first. Now, we can go through movement tests, we can go through all this stuff, and I think before you do that, I want you to understand what it is that you're looking for. Let's talk about what you're looking for first. And then what's the solution that you need to be able to provide? That's it. Before we talk about the exercise, before we talk about like, are you going to do a hinging exercise? Is the hamstring? I don't care. That's not what I'm here for. I need you to understand. Let's break down every single back case into 3 different things. Okay. And there's different research articles to go different down different rabbit holes within these 3 categories, but we're going to make this simple. I'm going to combine them into 3: mobility, stability, or programming. Mobility, stability, or programming. And within stability, you can call that movement, whatever, movement quality, or whatever you want to call it, movement analysis. But there's 3 different humans that we're talking about that have back pain. One person is stiffer. They just don't move really well in general. Or maybe they're really strong, big, bulky, and they don't have a lot of movement, a lot of mobility. And you can categorize these individuals just by the way they walk, the way they hinge, the way their hip mobility, their ankle mobility. You can kind of get a general picture just talking about this, right? These people just need more motion, more lotion. Motion is lotion, right? So you need those categories just need motion, right? Then you have people who are very mobile. Think about like a gymnast or an acrobat, right? Somebody who just moves really like excessively, and they don't need any more motion in their life. They don't need any more mobility. They really just need the stability, right? The quality movement, the stabilization to that. And so one person doesn't move well, and the other person doesn't stabilize well, right? And inside that, you have another category who, even if you got them really mobile, really stable, they continue to get hurt. And these are the people who come back to you no matter what. And these are the people who can move well. You've worked on stability, but they have a programming problem, meaning they don't know how to control their exercise routine with intensity or volume, or they're a high level athlete who has pretty good mobility and pretty good stability. And you find yourself like, I feel like I'm stuck. Like, I don't know what to do next because I've done all these things. They look good, they move good, and they have good stability. But the next challenge you run into is, well, do you know how to control with how much they do in a day, in a week, in a month, in a year? Well, no matter how much mobility and stability you get on people, if you don't understand programming, you can't manage them for longer than the period that you're trying to just get them out of pain. And that's the problem that you see. And if you are a pain specialist PT, meaning you only see people for 8 weeks and you can get them out of pain, and that's your job, and you send them out to the wild, and they come back every so often because you didn't know how to program, or you didn't know how, or you didn't think how big of a deal programming is. You're ultimately you're a pain cyclist, right? You're just waiting for them to hit pain again. You know that mobility is going to only last so long, stability is only going to last so long. So the only way you gain longevity in your outcomes is learning how to understand and integrate volume and intensity and managing those things for them via a Google sheet or an Excel spreadsheet or a program of some sort. So when you have a back pain patient, which one of the three are they? You have to determine that. And for most of you, it's one of the three, right? For some of you, it might be two of the three. There might be stability and programming, mobility and programming. Before you start diving into the weeds of, is it the SI, is it the hip, is it the combo? Physical therapists are by and large perfectionists, right? Like you're not okay with not being right. It has to be done just right. The comma has to be just perfect. The sentence has to read well. The notes all have to be complete. And what happens here is you get really laser focused on what the cause is. Like, oh, the tissue. What's the tissue involved? What's the one movement pattern that is going to fix this whole thing? And by the time it takes you 6 to 8 visits to figure that out, if you could have just categorized these individuals, attacked the heck out of that for a decent amount of time, you would have had better outcomes because you spent all this time dwelling on things that are insignificant. Yes, it's a SI. Sure, attack that. That's 20, 30% of it. Great. Well, what if it's the hip too? Great. Attack that 20, 30%. What if it's the back? 20, 30% there. And then work on the programming. So let's work on the hip, the SI, the back, and the programming. What are you going to lose? Nothing. But if you go the opposite and you dwell on the tissue, you dwell on the one movement pattern, it's going to take you days, weeks, months. You're losing time. And so my point to this is that the majority of people are not one or the other. They might be a blend of 60% is mobility, 20% is stability, and 20% is programming. Great. Figure that ratio out and move fast. But don't waste your time working on one region, one tissue, one movement quality that you think this is going to be the one. You waste all this time. Well, I thought it was a hamstring problem. Who cares? Why can't we do it all at the same rate? So back off of the tissue-based approach. Yes, it's important to know because of a tissue healing guideline. But from a solution standpoint, the rate at which you get your outcome will be determined on how quickly you can determine what is the root of the issue, how quickly you can solve that problem, how quickly you can adapt based on the weeks that they come back and they say that one didn't work. Great, switch, adjust, move. And when that patient finally has somebody who understands that it's probably a little bit of everything, they're not so type A OCD, they don't have to take 12 sessions to figure out this one thing, and they can move on faster, that allows you to make adjustments at the right time versus waiting 8 weeks and figuring out that you were wrong. So you're making it more complex than it needs to. That's number one. You're not sure if it's going to get better. So what do? You delay the time. You just buy yourself time, hoping that that one change is going to make a difference. So rather than look at if it's the SI, the hip, or the low back, let's assume it's all three and attack them at the appropriate ratios. Categorize your individuals into mobility, stability, into programming. Once you can figure those things out, it takes a lot of pressure off yourself because all the patient wants is a solution with some type of structure and a plan, right? So when you take this approach and you simplify, what is the root of the problem? A lot of times they want to know, well, when am I going to get better? And what is it, right? What typically happens is you label it according to the muscle attachment or the muscle. It's the multifidi, which then pulls your back into this and this. Got it. That's a tissue-based approach. Let them know that, listen, You have overactive muscles. So we're actually going to teach you how to stabilize so that way they don't have to turn on anymore. Once you've categorized it and they can understand, well, it's because you don't stabilize. That makes sense to them. What doesn't make sense is your iliopsoas is pulling you into a lumbar extension, also putting your pelvis into that position, and that's why you're getting the back pain. So what we have to do is really loosen. No, like let's stabilize. That's the focus for this 4-week period. After that, we're going to work a little bit less on stabilizing, get you more mobile, and then work on your programming to get you back to soccer, get you back to weightlifting, whatever it is. And so when you do things in stages, it helps them understand, oh, this part is I get more mobile. For the next 4 weeks, I get more stable. And then for the next 4 weeks after that, I get to work on all of my return to sport progressions. That makes sense to people. But when you categorize it under, well, it's your multifidi, it's overactive, and your iliopsoas is not doing this, like there's no solution to that. It's like, well, magically, when I loosen that up, it's going to reduce all of my pain, which is not the case because there's a reason why they got there and that they've probably been tight their whole life. What happened probably is that they did more volume or intensity than they were used to. They got into a sport that they haven't done in a long time. Nobody's helping them manage that. They just jumped into it, they did all of that while they happened to have an anterior pelvic tilt and a short iliopsoas from the beginning. So it wasn't that caused it. It was a contributor, but this large change in exercise or activity was probably the thing that created it. Yet we're over here assuming the musculoskeletal system was the thing that caused it the whole time. And if you take this approach that a portion is mobility, a portion is stability, and a portion is programming, you're always addressing all three. And that's very, very critical. So instead of delaying a tissue-based approach and assuming week-to-week changes are going to happen off of that, you need to understand, categorize people into something simple. Once you can identify, all right, I get what I'm looking for. Like that's the thing that, okay, I was looking too detailed and I just need to simplify it. Great. The last part you have to understand is people are looking for a solution on how long it's going to take them to get better. And the challenge you have is you're like, well, I don't want to overpromise. I don't know exactly when it's going to happen. So I won't say 6 weeks. I won't say 10 weeks. I won't do 12 weeks because what if I'm wrong? Then they're going to judge me. That's typically what happens with physical therapists. You're so concerned about being wrong or people thinking like, well, you said 6. I'm not better by that. You're gonna get mad. So what's the converse to that? What do you say instead? Well, let's just take it week by week so we know that you're on the right track. What you're doing is you're just delaying the inevitable. You're just hoping that one's going to win, and you're actually the things that you did today are going to be successful, and then you're hoping for next week for them to tell you they're better. And if they're not, they're going to adjust it a little bit, and they're going to ask you, well, how long is it going to take you better? And you're like, oh, let's just take it week by week. That's the physical therapist that has no confidence. That's the one that is delaying the inevitable because they're scared to be wrong. Now, you can't forecast 100% if somebody's going to be out of pain or not. That's very tough. I understand that. But what you can do is give them a guideline. The solution they want is, how long is this going to take me to get better? The real solution for you to provide is the exact time. While you can't provide that, you can provide the guidance, the guideline, the roadmap, and say, based on everything that I've seen, that your mobility, stability, or programming, given your active lifestyle, given that you have kids, given that you work as a whatever it is that you do, construction or whatever it is, I know confidently that you're going to be better, 90% better in 8 weeks. Now, there's a lot of factors involved in there. You have to do your iliopsoas stretching. You have to do your stability exercises so that way you're stabilizing the pelvis and not doing all those things. You have to sit down and not just stand in lumbar extension every other hour. You have to be compliant with everything we've talked about. You have to reduce your weight at the gym, as we talked about. Given all of those things, it puts you at a better position to be 90% by 8 weeks. If you don't do those things, it's going to set you back additional weeks. I would even say up to 12 weeks. Now, your effort plus my plan is going to set you up for success. I'll give you the perfect roadmap, but I can't do the work for you. And that will give you the best possible chance to be at the percent improvement that you want. And I heard this recently, and I really appreciate it. Your job as a physical therapist is not to fix people. Your job is to facilitate the process. From a molecular level, that psoas, that multifidi, isn't just going to relax when you do the tissue work, or it's not going to stay relaxed while you do the stretch or everything else. What is going to happen is you're going to give that patient or an athlete the tools to succeed, and it's their job to complete the tasks. So you didn't really fix anything. All you did was facilitate with resources, education, motivation, accountability, so that they were set up for success. But physical therapists, we want to be fixers. No, you're just a facilitator. And what that allows you to do is, once you categorize people into a simple category, you're like, wow, this is easy. You understand that you're not a fixer, or you're a facilitator. It takes the pressure off you dramatically. And it's the pressure that you have that you don't feel comfortable or confident with as a physical therapist. So rather than make it complex, how about we make it simple? Categorize them into 3 things. You are no longer a fixer, you're a facilitator. And the last one is, how do you determine how quickly you're going to get them better when they ask, so how long is this going to take? Let me give you 3 categories. 2 of the main categories help you break this down. Is their goal to be pain-free or to return to activity? Because those are 2 different things. Do they expect to be pain-free? And you may be like, well, of course. No, ask them. Or do they just want to get back to the gym? Because you can go back to the gym, but not be pain-free. What would you prefer if you had back pain? Would you want to be pain-free, or would you want to just return back to activity? I think the majority of us don't really care about a little bit of pain. We just want to be active. So let's break that down. We've talked about the tissue. We've talked about the categorizing the type of irritation that they have, whether it's the solution is mobility, stability, or programming. Simplify the goal. Do they expect to be pain-free or return to activity? And then the last part about that, I told you three different categories. One is pain-free. The other one is return to activity. And the last one is there a time-based approach to this case? If they want to be pain-free, you need to have that conversation of, well, pain-free might not ever exist because you're going to be traumatizing your body and the musculoskeletal system with exercise. If they just want to return to activity, what's the time? And is there any form of urgency? If there's a form of urgency, the likelihood that you get them back to 100% in a short timeline that don't match their soft tissue healing guidelines is going to be much less. And that conversation needs to happen at that initial evaluation. So to make this easy, anytime you're dealing with low back pain, the first thing to do is categorize them into mobility, stability, and programming. Understand that you are a facilitator, not a fixer. And last but not least, simplify the goal. Do they want to be pain-free, or do they want to return to activity? And if they want to return to activity, is there a time-based component? If there's a time-based component, you have to have that conversation of what's the expectation? What percent would you be able to confidently forecast that they can get better? And if you can't confidently give the percentage of improvement, you're going week by week. You're the let's see how it goes physical therapist, because you don't have confidence in your decision making. You don't have confidence in what you're forecasting, or you're scared that somebody's going to judge you for being wrong. And the reality is the patient doesn't care. It is your internal challenge to be able to give that and deliver that information. Why? Because the patient doesn't matter. They just want an idea. If you were to talk to a mechanic about an issue with your car and they said, hey, 90% chance this is the problem, you'd be like, great, I'll go with that chance. It's a 50% chance that this is going to keep the oil from dropping. Is there another option, as you would say? And all it does is allows the conversation of, well, there's got to be a better way. I either increase the length of your return to sport, or you hustle and you figure out how much you can do inside this. And that's fine. But that creates a better relationship to understand that the patient now has most of the onus on them. And that's how you solve back pain. That's why I love back pain patients and athletes, because I love having those conversations. I can fix things. I know I can, but I'm a better facilitator. I understand where people's challenges are. I understand where your challenge as a physical therapist is. And all I can do is guide you, give you the bumpers to create success for yourself. But I know the internal reason why you don't want to do this is because you're scared of failure, you're scared to be judged, you're scared for that patient to say that you were wrong, when in reality, it doesn't matter. All they need is guidelines. Can you confidently deliver that? So while I can give you hamstring stretches, I can give you hip mobility stretches and everything else, all of that is irrelevant if you can't deliver this framework. Why? Because they're not here for the exercise, they're here for the solution. And if you can't confidently and easily communicate that, your complex PT verbiage is not going to help them understand how they can get better. And if you want to facilitate independence, you want to make sure that they can do this on their own. The number one thing you can do, make it simple, easy for them to understand, and achievable. And if you can do those three things, you're going to have the success that you want. And for low back pain patients, this is particularly true because you have referral, you have issues at the low back, you have muscles, you have SI, you have all these complex things. Put it into an easy package that your patients and athletes can understand. And that's what you're missing. And what you need to be looking for is not more exercises, but how to make your sessions more simple, not complex, with more exercises. And that is what I want you to take home with you as you navigate this. So there you have it. Those are simple, easy things to do inside Clinical Pros for low back pain. If you love this, if you're like, man, I love working with back pain patients, but I need a little bit better of a framework. This is everything that I cover inside two of my programs. Number one is my Sports PT Academy, where I mentor physical therapists like yourself who are navigating these challenges and help them see a bigger picture on how to just simplify this thing we call physical therapy in a job. It's really, really simple and foundational and simple. I promise you, it's so easy when you can see it from a different lens. And the second part is if you work with barbell athletes and you are stuck in certain positions and you can't seem to work with a CrossFitter, you can't seem to help a Olympic weightlifter, a power lifter, and those are the patients that you want to see or you see them currently, you have to attend my Management of the Barbell Athlete course. This year it is it's in 2023, October 28th and 29th. It is on my website, drchrisgarcia.com/barbell. But this gives you a chance to hone in on your skills on back pain, shoulder pain, knee pain with barbell athletes. If not, join my academy. It's where I mentor physical therapists, sports physical therapists, particularly on how to easily navigate your professional path and navigate these complex cases that can be easily packaged into simple fundamental principles. So there you have it. I hope that helps in your clinical practice. I hope that you guys are thriving and enjoying life and treating a lot of back pain with phenomenal outcomes. Nonetheless, I will see you guys on the next episode. I hope you're crushing life and enjoying every minute of it. All right. See you guys.